I'd like to begin by apologizing for the juvenile diatribe from the ranking member. Science is about having an open mind. Science is about disputation, debate, evidence, and it's discussed. And the contention and the back and forth is how we determine what the truth is. But if you close your mind completely to this and are not willing to listen, I think that's how science dies. That's when we say, well, the government consensus or the scientific consensus is this. Well, that's the closing of the scientific mind, and that's a recipe for a disaster. Science is also not about ad hominem and attacks. So by attacking this panel without listening to it, leaving in a huff, and having no questions, shows a small-mindedness, a closed-mindedness, and really it should be everything that we should avoid. I'm not here to be an advocate for one treatment over the other, and I will ask some tough questions to the panel. But I'm open-minded enough to listen to their side and see and try to determine whether or not it's a good treatment or bad. But to immediately close our mind, I think is a bad way of looking at this. I had a good friend die yesterday from this, so I'm not one who's saying this isn't a deadly disease. She lived a couple doors down, and we're sad. Kelly and I are both sad about what happened. About 6 months ago, we had a friend who died in their 30s, not from the disease, but from lack of a stress EKG. She died from a terminal arrhythmia in her 30s with 2 young children, but her stress EKG was canceled because the government decided that we shouldn't do it. It was an elective procedure. It was delayed, and she died from a terminal arrhythmia. So people do also die from the decisions that people make. The most important thing is no one person is right. The panelists are not all right, and people should question them and go back and forth, and we try to figure out the truth from that. But it's a mistake to say that one person should have all the power to determine what we should do when we place too much confidence in government doctors such as Dr. Fauci. Dr. Corey mentioned that he mentioned in June about steroids. I mentioned it in March when Dr. Fauci came into my committee hearing. My first thought about the final pathway here with COVID in the end stages is it's not too dissimilar from other final pathways of adult respiratory distress syndrome. I had a friend who's a surgeon who got the strep eating flesh from operating on somebody who had it, and a blood splatter. He got it. The chance of losing your limbs is like 50 to 70%. It's like a 50% chance of losing all your limbs. I mean, it's a devastating disease, but one of the final common pathways like COVID is your blood vessels leak fluid into your lungs. It's a sort of a toxic shock kind of syndrome. They treated him with high-dose steroids, and so I raised my hand to Dr. Fauci and said, do you think steroids might have a role in this? And he sort of dismissed me and said that the studies were showing that it probably wouldn't work. But I would think most people would argue now that one of the most significant developments in the acute care of the COVID patient has been the steroids, actually, and trying to get them the steroids before they've gotten into the full ARDS syndrome. Some are even getting it at a very early stage in the disease. But that came from people asking questions, being skeptical, and not letting one doctor, such as Dr. Fauci, say, oh, that's not right, young man, go sit in the corner. We need to have an open mind. I'm not saying I'm always right. I'm a bystander, and I'm not an expert in COVID, but I try to ask the important questions. One of the questions that I'd like to ask, and I think this is the difficulty of proving the situation on either ivermectin or hydroxychloroquine, is that because so many people get better, you know, the control group might be 99% of the people get better. Then you give hydroxychloroquine to this same group, and you might get 99.5%. It's going to be a difficult thing to actually prove in trials that you get a benefit. It sounds like in some of the sicker patients where you had a mortality, where you had a 25% mortality down to 15%, that does sound significant. Now you're getting into the sicker patients. With the outpatient studies, one of the critiques is that so many people get better naturally. How are you proving that it's statistically significant? And what comes to my mind is sort of like when we wanted to prove that taking an aspirin a day was good to prevent heart attacks. It took like 10 years and 10,000, people in the study because it was just hard to show the differences of whether an aspirin worked or not. I think the same thing is true with either hydroxychloroquine or ivermectin in an outpatient setting, is that because so many people get better on their own. The converse is when you're really sick, because it's hard to get to treat people who are very sick. It's hard to prove that anything works when people are very sick. But I guess what I'd like to do is open it for the panel one by one to explain how we answer the critique that most of these people are getting better anyway, so how you've proven that your treatment works in a group of people who didn't go to the hospital, so that you're selecting out actually for the people who may well have been, did you prevent them from getting seriously sick, or have you selected out as your patient pool because they're outpatient, tending to be people who are going to get better? Why don't we'll start with those who are here. We'll start with Dr. Oskoui, and then we'll go to Dr. Corey.
And let me quick interject, because we have such low participation. Take whatever time you have for whatever questions you have. Dr. Oskoui.
Thank you very much, Senator Paul, and I appreciate your introduction. I'm not here as a politician. I'm here as a treater. I'll be very practical, and I'll defer to Dr. Corey from his experience as an intensivist. My clinical approach to patients are that they have symptoms, that I treat them early, and I typically risk stratify patients getting LDH levels, lymphocyte counts, and other blood panels whenever possible. When I've used hydroxychloroquine and oftentimes ivermectin, I've had patients go to the hospital if I didn't have an EKG or another good assessment, and I've always clinically evaluated the patients I've treated. But I risk stratify them. You may or may not know a husband and wife couple that I know Senator Johnson knows, who I treated the wife and not the husband, because I didn't deem the husband to be sick enough to warrant treatment, although perfectly safe to, but his wife was much sicker. So I think this has to be, to some degree, left in the discretion of the clinicians. In terms of the data, I provided the clerk of this committee, Ms. Kilbride, PDFs of numerous clinical trials on many of these drugs, not limited but including hydroxychloroquine, ivermectin, vitamin D, zinc, and a few other medications, and those trials are there. But the fact that we've had third world countries, second world countries that have been more innovative and have outperformed us in terms of survival, I think is something that warrants questioning. And it's one has to wonder if our bloated research academic bureaucracy has been more of a hindrance than a help during this healthcare crisis. But I'll turn this to whomever. I hope that's satisfactory.
Dr. Corey.